I'm glad to introduce the next speaker, Dr. Xu Zhijian. Dr. Xu is a graduate from National Yangming University and complete his PhD program also in the National Yangming University. He completed his training in Taipei Veterans General Hospital and now served in the cornea service. Let's welcome Dr. Xu.
Okay. Thank you, Chairman, ladies and gentlemen. I'm Chichen Xu from Taipei Veteran General Hospital. Today, the topic I want to present is the suitability of a toric IOL in patients with corneal scar. This is a 66-year-old male, and he had treated complaint of blurred vision in both eyes in recent 1 year. Long time ago, he had no myopia, but some have high degree of astigmatism. He had bilateral corneal scars in both eyes and cataract in both eyes, and then this is his auto refraction. We can see myopia and high astigmatism, and the best correct vision in both eyes is 650. So this is the data of lens star. We can see the range of the astigmatism is around here, and the axis is quite stable. The left eye, the same condition. We can see obvious corneal scar here at the central area in the right eye, and in the left eye there are also fan scars here. This is the lens conditions in both eyes. So this is the dysfunction lens index in the right eye. We can see the lens dysfunction lens index is quite high, and it shows that there is high corneal aberrations here. The same in the left eyes. The dysfunctional lens index is quite high. So, Dr. Tin, so how do you think? Should the patient undergo cataract surgery?
This may be a question because the patient has a very high DLI value, and because DLI value range from 0 to 10, and the lower value correlated to a more dysfunctional lens, indication cataract, while an increasing number, just like the patient, the value of A correlated with a better lens performance. But the value could be related to with age, pupil diameter, and the high order aberration. Although the DLI could be considered to assist optimal timing to perceive lens change, the variability of the implies the necessity of a combine with other diagnosing measurement. So I will suggest the patient undergo the cataract surgery.
Thank you, Dr. Thomas. What's your opinion?
Eye trace is a waveform machine. It uses ray tracing, aberrometer, and placidocorneal topography to distinguish the aberration is from cornea or from lens. The functional lens index is based on spherical aberration of your lens. When you are young, it is negative. When you are older, it became positive. You can see the internal waveform E is so blurred, but the dysfunctional lens index is high. Why is that? Because the dysfunctional lens index is a result of total aberration minus cornea aberration. The cornea spherical aberration is too high, which is detected by the posterior rim, and the lens spherical aberration will be fake low. It is false negative. So you may see the E is so blurred, but the index is high. So it's a false negative.
Okay, thank you. So because the patients never has myopia before, and he never wear glasses, so in such conditions, recently he has myopia and high astigmatism. So the patient decided to undergo cataract surgery in both eyes. So what should the second question is, what should we consider before cataract surgery? Dr. Tan, in such kind of patients.
the pinhole visual acuity. If the visual acuity improves, the patient will get the benefit from the RGP or scalar lens. On the other hand, he may consider the simultaneously cornea transplant and the cataracts surgery if the visual acuity not improve. However, according to the picture of the right eye, the cornea scar may need to the PKP, which will increase the astigmatism value. So if we perform cataract only and cataract surgery only, and the scar is too large, but in the right eye, the scar is not too large to obscure the visual field. But if the scar is too large to obscure the surgical visual field, extra intraocular illumination may be needed.
Okay, thank you. Dr. Thomas, what is your opinion?
There are obvious cornea scar at central cornea area. Irregular astigmatism is an issue we should be concerned. We should give the patient several solutions for the irregular astigmatism, like PKP, a dog, or high contact lens, or trans PRK. We should always remember cornea surgery should do first, and then cataract surgery later.
Okay, thank you. Thank you for your opinions. So we discussed about with the patients, will you undergo cornea transplantation or some refractive surgery or use RGP if the corneal scar affect visions? Because if the patient is willing to receive the cornea transplantation or even RGP use, then toric IOL should not be considered, because when you do such kind of procedures, the astigmatism of the toric IOL will appear. If the patient don't want to undergo cornea transplant or use RGPs, I think the toric IOL can be considered to resolving his high astigmatism, because the patient is not willing to wear glasses or contact lens or doing any further procedures. So we decide to consider toric IOL for this kind of patients. So we can see this is the topography in the left eyes. And we can see this is the topo. And the scale is about 2 diopters in each scales. And the scale is about 0.5 diopters. So we can see the other data. This is the topo. And this is K value of the lens star. So the question 3 is, can I put a toric IOL in the left eye, Dr. Tian?
Low is an irregular astigmatism, but the axis of astigmatism was still stable during the 3 times of examination. So yes, I will recommend the toric IOL.
Dr. Thomas?
Most eye with astigmatism post-trauma have some component of regular and irregular astigmatism. Benefit of reduction of astigmatism with toric IOL has been reported in eyes with irregular astigmatism due to keratoconus or cornea transplantation. Reduction of the high amount of refractive astigmatism is benefit for this patient. Toric IOL implantation is a safe and effective tool for reducing refractive astigmatism following cataract surgery in these eyes. Toric IOL can be considered in 3 situations. First, no contact lens were anticipated. Second, spectacle correction with astigmatism correction pre-cataract give good vision. Third, topography shows stable regular astigmatism in central 3 mm. As I mentioned before, there are 3 criteria we suggest. Criteria 1, you can see the topography, see there are regular bow tie astigmatism within central 3 mm zone. Criteria 2, difference in corneal astigmatism magnitude between the different optic biometry was less than 0.75 diopter, and some doctors say less than 1 diopter is also a criteria. Criteria 3, difference is in astigmatism meridian between different optic biometry is less than 15 degrees. Thank you.
Okay, thank you. So because combine all of these data, and I think the axis is safer to choose the axis at around 180. So this is the adapter of astigmatism I want to correct. So finally, I put an IOL target plane here. And this is the result of 6 months later. The axis is still the same and don't change. And his vision acuity is 6/10. And if corrected with -5 myopia, it can reach to 6/8.6. So this is his right eyes. So this is the topo. And this is the scale, when the scale is around 2 diopters. And the scale is about 0.5 diopters. And we can see it is a symmetrical bow tie pattern. So this is the K value of the lens star. So question 4, can I put a toric IOL in the right eye according to this kind of value, the data? Dr. Tian?
Low the lesion is more obvious than the left eye. The axis of the central cornea was still quite stable. And otherwise, the information of the astigmatism are quite comparable between the lens star and the eye trace. So yes, I will still try the toric IOL for this eye.
Dr. Thomas?
This eye has both regular and irregular astigmatism. Although his bow tie pattern shows irregular and asymmetric, his astigmatism slip axis is obvious. This patient can get improvement with toric IOL implantation to correct his low-order aberration. I will correct the small part of his asymmetrical bow tie astigmatism. It's about 2 diopter. That the large part slip cornea uncorrected. It's like a keratoconus. It's like a bifocal cornea. A patient can read without glasses.
Thank you for your opinions. So because the patient don't want to wear glasses, so I still try to put a toric IOL for these patients. This is the axis I choose. And I want to correct about 2.50 degree of astigmatism. So this is how I put. So 4 months later, the refraction status is here. But the patient's visual acuity can be further corrected with the refraction status. This is a paper that showed the toric IOL implantation in cataract patients with corneal opacity. This study includes 31 eyes, and their results found that toric implantation can improve the uncorrected visual acuity, best correct visual acuity, and refractive astigmatism in cataract patients with corneal opacities. However, undercorrection of astigmatism is common. And they thought the size of corneal opacity covering pupil is the major prognosis factors. And they think the patient with pericentral corneal opacity are the best candidate. But if corneal opacity did not cover the whole central pupillary area, good vision can still be achieved. So conclusions, in patients with corneal scars who want to undergo cataract surgeries, lens dysfunction index in eye trace examination is less reliable because the high aberration in the cornea is too large. And we should discuss with patients next step if the vision is affected by corneal scars. And we should choose a suitable toric IOL for your patient with corneal scars if his astigmatism is relatively correctable. Thank you for the attention.
I will invite a question from the audience. Do you have any questions?
Zhijian, excellent talk. I appreciate your sharing the cases for corneal opacity and how you deal with this patient. Especially, I think for these complicated cases, we should use multimodal image to evaluate preoperative and to get aligned with each other to perform the further surgery. I'm just curious about your last case, which you showed the question 4. I don't know if any corneal specialist can give us any comments or any opinion about this case. I think it's approaching the central visual axis. For this patient, probably I would not directly perform the cataract. If the patient cataract is not very severe, because I think the total solution for this patient is my final goal. Though, despite you achieve the maybe 6/8 corrective visual acuity. For this patient, I will perform anterior segment OCT first, and I will check the corneal scar, the depth of the corneal scar. If possible, I will proceed to maybe therapeutic keratectomy first. This is my first opinion about this case, and then I design the cataract surgery and choose the proper lens for this patient. Otherwise, I will consider another option is the DELC. Okay, DELC, probably maybe you can do this and achieve the optical clear corneal surface and then do the next cataract surgery. This is my comments, but you did it very well. So I just share my opinion about this case.
Yes, in such because the patient we have do the anterior segment OCT for the patient, and his scar is quite deep. The other side is the patient don't want to receive any refractive surgery, except he just want to do cataract surgery. So that's why we choose the toric IOL for these patients. Thank you.
Good evening. Excellent presentations. Thank you, and thank you for having me here. I'm Dr. Parul from India. Just want to make a comment for the audience as well, because whenever we have a combination of irregular astigmatism and a regular one with corneal opacities and other factors, I think it's very, very safe to go ahead with toric because it will debulk the majority of your astigmatism, even if it doesn't correct anything fully. And one small tip with corneal scars is to use a plano contact lens, a hard contact lens. If your patient's vision improves, that means that is irregular astigmatism, which is becoming okay with contact lens. That part you cannot correct. But if the vision is same with the contact lens and without, then you know that irregular astigmatism is not much of a problem, and you can safely go ahead and do the toric IOL because it corrects majority of your astigmatism and the patient is happy, and that's exactly what you did, and I think it's a great choice. Also, the previous comment, and I saw the confusion where in RK we were talking about EDOF. I do a lot of VVT and diffractive. Out of all the presbyopic IOLs, the EDOF, the VVT platform, is still more forgiving. It acts more like a monofocal and an added intermediate correction, so there is no major downside to it as in diffractive. So if the patient actually wants and there's not much irregular astigmatism, we can go ahead and still do EDOF. So I agree with the previous speaker also on his choice. So both of the case selection and the choices are great. I agree with what you've done.
Thanks for your comment. I've done a lot from your comments. Thank you.
Thank you, Dr. Xu.